dear Chairman, dear colleagues. Congenital hip dislocation is one of the most important and challenging topics in pediatric orthopedics. In our research, we are evaluating the conventional treatment of hip dislocation in order to find the most personalized treatment protocol. My name is Gyula Domos. I work as a pediatric orthopedic surgeon at Semmelweis University, and my vision is to ensure the highest quality treatment for our pediatric patients and also to build one of the best pediatric orthopedic centers in Europe in 10-15 years. In order to achieve this aim, we have to introduce the best available treatment methods in every field of pediatric orthopedics, and we also have to work out new treatment protocols. My current research fits well into this concept. In the first part, we are investigating the risk factors of failure in the treatment of congenital hip dislocation. Based on a systematic review and meta-analysis, we would like to define how we can reach the best results and avoid complications. In the second part, we are analyzing the results of our treatment protocol at Semmelweis University, which is different from the international protocol, but we seem to have better results and less complications with that. Because of the large number of publications and high amount of data, we divided the first project into 3 topics according to the different treatment steps in hip dislocation. So the first 3 projects are about the risk factors of failure in the treatment of congenital hip dislocation. Let's see how the 3 projects join each other. According to the international protocol, after a failed conservative treatment or in case of late diagnosis, a close reduction of the dislocated femoral head is performed under general anesthesia. If the close reduction fails, an open surgical reduction is needed. If the open reduction phase 2, complex surgery, open reduction and femoral and/or pelvic osteotomy is performed. But complications are quite common with this treatment regimen. Unsuccessful reduction and redislocation are the main reasons for failure. In addition, the most serious complication of the treatment, the avascular necrosis of the femoral head, is common too. The overall rate of it is 10% in closed and 20% in open reduction. What we don't know is the overall rate of failure and the risk factors of failure. But if we could identify the cases where the conservative treatment will probably fail, we could skip the conservative step in the treatment and we could perform a close reduction immediately. Thereby, we could avoid several complications and unnecessary interventions. And if we could select the cases where the close reduction is likely to fail, we could skip the close reduction step and we could perform an open reduction immediately. And based on this scheme, we could perform a complex surgery if the open reduction will also probably fail. So our questions are, what are the risk factors and the overall rate of failure in the treatment of congenital hip dislocation? We are investigating 3 groups: children with conservative treatment, with close reduction and open reduction, and the intervention is the presence of risk factors, and the comparison is the absence of risk factors, and the outcome is the rate of failure. Our hypothesis is that certain risk factors increase the rate of failure in the treatment of congenital hip dislocation. I performed a systematic search in October 2021. My search was about hip dislocation and reduction, and we found more than 12,000 records and 200 eligible full text were selected. These publications covered the 3 topics: the conservative treatment, the close reduction and open reduction, and we found 68 publications regarding risk factors and 132 other publications with only data about the failure rate. So having decided to divide the first project into 3 topics, I performed a systematic search in close reduction again, and we found 62 eligible full texts. In the close reduction topic, we found 5 different types of failure data. The rate of primary failure was 13%. This group consists of 2 subgroups. The intraoperative failure is when the dislocated femoral head is not reducible under a general anesthesia in the operating room and an open surgical reduction is needed. The rate of it is 24%. And the postoperative failure is when only the postoperative CT or MRI scan shows that the primary reduction attempt was not successful. The rate of it is 7%. But after a successful primary reduction, redislocation can also occur. The rate of it is 8%, and the overall rate of failure was 20%. We investigated 71 potential risk factors, and we had 134 forest plots, and we found several significant risk factors which are marked with red dots on this summary plot. We found that grade of dislocation significantly influences the risk of failure. In low dislocations, the rate of failure was significantly lower, and in high dislocations, the risk of failure was significantly higher. And we found that a high dislocation is a significant risk factor regardless of the classification system, and we also defined the overall rate of failure in these high-risk patient groups. We also found another important result. Male gender was a significant risk factor for failure. There are several strengths of our study. This is the first systematic review regarding the risk factors of failure, and this is the most comprehensive meta-analysis in the topic of hip dislocation treatment. And we were also able to identify high-risk patient groups. But there are some limitations too. Publications do not consistently investigate and define the failure groups, and the treatment protocol was not exactly the same in all institutions. So the conclusion of our study is that the risk of failure in cross reduction is high in high dislocations and in male patients, and in these high-risk patient groups, we advise to perform open reduction instead of closed reduction to avoid complications and unnecessary interventions. But randomized clinical trials could clarify what other risk factors increase the rate of failure in these high-risk patient groups. The first manuscript in closed reduction topic is under review at the Journal of Bone and Joint Surgery. Regarding the other topics, we found that the overall rate of failure was 10% in open reduction, and we didn't find any significant risk factors in open reduction group, and data processing is almost finished in conservative treatment group. In our last project, we are analyzing the data of our patients with congenital hip dislocation treated by primary complex surgery at our institution. At Semmelweis University, we don't use the intershore protocol of hip dislocation treatment after a failed conservative treatment or in case of late diagnosis because of the high rate of failure and avascular necrosis. During the treatment, we would like to avoid the forced reduction of the dislocated femoral head because it can damage blood supply and can cause avascular necrosis. As we cannot select the cases where the conventional treatment is likely to fail and an avascular necrosis will develop, we skip the closed reduction and open reduction treatment steps and perform a complex surgery with open reduction, femoral shortening, osteotomy, and joint reconstruction. In this study, we are investigating the rate of failure and rate of avascular necrosis. We retrospectively reviewed our patients with congenital hip dislocation who had been treated at our institution between January 2008 and December 2020 with open reduction and femoral osteotomy with a minimum 2 years follow-up. We excluded patients with neuromuscular diseases. During this period, we treated 86 patients, and we excluded 60 patients with associated syndromes and 9 other patients with less than 2 years follow-up. In 61 patients, we performed 70 hip surgeries, 46 surgeries in patients with previously failed conservative treatment, and 24 surgeries without previously failed conservative treatment. Only one hip redislocated, so the overall rate of failure was only 1%. Out of the 70 hips, 60 X-rays were available for further radiological analysis, and we found avascular necrosis in 6 hips, so the rate of AVM was 10%. However, the rate of avascular necrosis was only 4% in patients without previously failed conservative treatment. So in our first project, I defined the rate of failure in hip dislocation treatment. It was 20% in closed reduction and 10% in open reduction. And in our second project, I investigated the results of our treatment protocol at Semmelweis University, and we found only 1% overall failure rate. Although the rate of avascular necrosis was 10%, it was only 4% in previously untreated hips. So the first manuscript is under review, and I'm planning to finish the second in August, and then the third one on conservative treatment topic in December. I had 3 conference presentations, one at the annual meeting of the European Pediatric Orthopedic Society, and two presentations at the annual meetings of the Hungarian Orthopedic Society. And I brought a quote from István Szepsi, who is a famous and internationally recognized winemaker. His words that the highest quality is our moral duty is also a very important rule in medicine, especially when we treat children. Thank you for your attention.
Congratulations, very fine progress again. And then as you can connect actually your in silico work with your clinical work, I think that is great. Can we go to your first project for this male-female issue? I mean, there is a forest spot on that. Okay, so, I mean, we see the numerical values. Still, there are 3 studies which are actually saying that in male this is more frequent, and in one study when it says actually the opposite, although the range is very wide and the number of cases are very small. So could we really kind of conclude from this sample size, especially because there is there is one which actually had a reasonable kind of big number. I shouldn't say anything, but this is again, the question is what the truth is. And also, I mean, is there anything difference in the different kind of way of sampling or so in the first study compared to the others?
These are weighted data, and if you look at the first row, it's only almost 2% of the patients, so it's not a very important result in this.
Then actually, this is why we do meta-analysis, because there are lots of uncertainties in individual studies, and then you put together, I mean, you will get a higher level of evidence anyway. But I'm just worried a little bit whether this is really clinically relevant in a case that really is more frequent in males, or it does just depend on the on the sampling and then the relatively small number.
So in the clinical relevance is that in male patients we often see any other associated syndrome or clubfoot or any other problems, and maybe sometimes we cannot detect them, and so hip dysplasia and hip dislocation in male patients is not a simple hip dislocation like in females or in girls.
Coming back to a very good presentation with, I think, a lot of clinical evidence and clinical implications. So coming back to your point, and you answered it almost half, what do you think is the reason why male might be more reliable to have failures than the girls? Might it also be muscle strength? Does that play a role in infants?
No, I think the dysplasia, the hip dysplasia, is more complex than in a simple average dysplasia. Maybe about the improving potential of the dysplastic acetabulum, probably, or maybe what you said, tight muscles. We don't know exactly, but we can see it in the clinical days.
Yeah, thank you. It's I think, fair answer. And for your clinical implications, you mentioned that you found out something in your own after a follow-up of 12 years or something in your patient cohort. So what do you change in your clinical daily practice?
In our clinical?
Yes, of course.
Nothing. Nothing. Because so if you decide what protocol you use in your clinic, you have to take into account not only the failure rate, the avascular rate, but you have to consider the secondary surgeries, the late results as well. And we don't have enough information about these things. So nowadays, I don't want to, or we don't want to change our treatment protocol, but maybe in a few years after having these informations about secondary surgeries and late results, maybe we can change it, but not now.
Thank you.
A small comment to that. I think you presented on the first slide that you have already changed the protocol, and this protocol is different from the international protocols which are used nowadays. So he wants to be sure that this different protocol is better than the others.
Thank you.
My question would be, you mentioned that the high dislocation has a worse prognosis than the others. It is a high risk factor. But what's about the anteversion of the femur? So it was measured in the literature, the size of the anteversion, and how was it measured, and is that high risk factor or it's not so important?
Yeah, thank you for your question. It's a very important issue. Most of the publications do not measure the anteversion, but we know in high dislocations the anteversion is more pronounced than in low dislocations. So it's probably a very important factor, but usually we don't measure it.
My original question was the male-female difference as well, but I go to the other subject. Going back to 1980s, I spent quite a time in the pediatric unit, and at that time Professor Viscaretti was the head of the unit. So I heard all the time, and I try to remember, but I haven't seen a close reduction in hip spica. I haven't seen a single one at the unit. All went for open reduction surgery, complex surgery. But looking at your results, all the time was said that the problem is the avascular necrosis, trying to reduce the hip and to put in the spica. We have been afraid of avascular necrosis. But looking at your results, it was 10% in the literature, and with open reduction, it was 20%. I mean the avascular necrosis. And in spite of this, we shouldn't change the practice, the everyday practice, thinking on trying to conservatively, and just the failed conservative should go for open surgery.
It's a really very important issue. This is so if there is a patient with hip dislocation and with a successful open reduction, and he or she has avascular necrosis, but this patient had previously an unsuccessful conservative treatment, unsuccessful close reduction, we think that the reason for the avascular necrosis is the open reduction, but I think this is not the fact. So the unsuccessful conservative treatment and close reduction is the reason for the avascular necrosis, but we always evaluate after the open reduction.
May I ask you, if I right understood, the avascular necrosis after the operations in our material was 10%, not 20%?
Yes, but in the literature it was 20%.
In the literature, okay.
In the last two rows, if you look at the last two rows, the rate of avascular necrosis with a previously failed conservative treatment was 14%. It's almost 20%, like in the literature. But without a previously failed treatment, it was only 4%. So when we perform the surgery on an intact, untreated hip, the rate of avascular necrosis is very low.
So in 1980s, Professor Viscaretti's indication was absolutely correct. Not trying conservative treatment, open it up and do the complex surgery.
Yes, but nobody believes it, but he had right.
Do you have to perform secondary surgery after successful open reduction in your institute or not?
There are some issues in hip dislocation treatment. One is the dislocation, and the other is the dysplasia of the acetabulum or the hip joint. The open reduction is only for reduction for the first step. This is the most important step. But there is another issue, the dysplasia, and we often or quite often perform secondary surgeries in these patients. So in these 70 hips, we performed or planned in 34% a pelvic osteotomy later. And this is the average rate of, in our institution, of the secondary surgeries. And the average rate of secondary surgeries in the literature is between 30 and 60%. So it's quite an average in our institution.
Thank you very much. Which type of pelvic osteotomy did you use?
We use Pemberton osteotomy always.
And in the literature, there is an offer for these cases, or
mostly they perform Salter osteotomy because it's technically easier.
Just wanting to come back to this question of the avascular necrosis, is that in your practice, did you see avascular necrosis before the surgery as well?
Out of the 70 hips, we were able to perform the radiological analysis in 64 patients or 64 hips, and we excluded 4 hips because we noticed in 4 cases an avascular necrosis before the surgery, and that's why 60 remained.
Did you made any statistics in case of the second project?
Thank you for the question. Not yet.
Not yet.
I've just finished these statistics, so these results. So I haven't done any statistical analysis.
Could you back, please, to the forest plots with these males? Good, thank you. How would you interpret the confidence interval on your plot?
So the confidence interval is the interval within which the original parameter lies with a given probability. So in this case, with 95% probability.
Do you think it is a wide or a narrow confidence interval? How would you interpret this?
It's not a really narrow, but it's narrower than the others.
Thank you.
Maybe one last question from my side, at least. I would say, what is the if you're talking about numbers of places, do you see now in Hungary the incidence is decreasing of high hip dislocations because of genetic changes, because of changes of people who come from outside, as we see in Germany, from other countries?
Unfortunately not.
Okay.
Because we don't have a universal hip screening system.
You don't have?
No.
Okay.
Well, I mean, we have a universal, but not with ultrasonographically. So then that's the difference. It's only clinic, and we use selective ultrasound screening, but not in our institution. We use, so we perform the ultrasound examination in every patient or every baby, but not in the country.
Because this is a reason why, for instance, in Germany and other countries, the numbers dramatically went down. Now we see from the people who come from abroad, we see late dislocations, which we haven't seen in Germany for many years.
Fortunately, we have to admit that the screening is getting less and less, worse and worse in Hungary. At that time, when Professor Viszkeleti organized that, it was much, much better. Something happened, and we have discussed at the meeting in country, we have to improve the screening.
Yes, we are planning to introduce the universal ultrasound screening.